Good afternoon, everyone, and welcome to Care Patrol's Tuesday and Thursday educational series. We appreciate you coming in. I hope it is as beautiful where you are as it is here in Birmingham. It's just gorgeous. It feels terrific outside. I'm sure we're going to get snow again soon. Hopefully things are going well in your world as they are in ours. And just a little bit as we're waiting for folks to come and join us and get started, I'll tell you a little bit more about our series of education and how we got started and what we do and what we're hoping to achieve. So those of you who've tuned in and expected to find Jay Jones will discover that Jay has taken a different position with a different company right at home. I know that he will begin offering education again, I believe in March. And so be on the lookout for that. He was wonderful to set up this series for us and for you. And we appreciate it and intend to keep going. And the reason being that the thing that I think differentiates our placement service at Care Patrol from others is that we I'm sorry, I'm trying to admit people. We provide guidance and hand-to-hand, face-to-face assistance. And so we're advocating for our clients, we're discovering their needs, educating them about what solutions exist for them. And so I want for Care Patrol to be known among, all folks, certainly clinicians, as the experts. Call the experts, call Care Patrol. If we don't know the answer, we'll find it. And will save you and the family a lot of turmoil in the meantime. So today's series and the series that will continue now in Jay's absence on Tuesdays and Thursdays will address various topics. Some will relate to elder care, which is where we focus at Care Patrol. Others will relate to, other populations and demographics and other disease states that are important to you. I know that each of you work in different different capacities and different clinics and different settings. And so we'll hope to find topics that are, of interest to you. And to that end, we'd like you to share topics of interest with us. You'll find it in our survey questions. And to that, I hope I've gotten better with the survey. Those who've been with us before and the last two sessions that I've led have learned, unfortunately, that there have been some issues with SurveyMonkey, which is the evaluation tool that we use. And this is, I would say, all user error on my part, not on yours and not on SurveyMonkey's. It's my inability thus far to set up the survey appropriately. But today, fingers crossed, I've done it right. So I'm hoping that this works seamlessly today, that each of you who are in attendance will get your CEUs without having to chase me down as you've been doing So we thank each of you for being in here today. Today's topic is dementia in the emergency department, or ED or ER, however, whichever acronym you choose to use. We will begin doing some housekeeping. So as you come into today's meeting, please mute your phone or your computer during the presentation. Particularly those of you who are on a phone. Sometimes if a call or a text comes in, it may somehow inadvertently kick you off of mute. So please be mindful of your phones when listening in. Now, I'm hoping, and I say this each week, and I'm going to continue saying it, I'm hoping that we can use the chat room as an arena for you all to share ideas and information with one another, not just me. So while we try and be the experts and understand the topics that we're presenting, hopefully well enough to enlighten you, we also know that there's a lot of wisdom in this room, so to speak, among each of you. And we hope that you'll share it with one another and with me. I'd love to have your questions and interactions throughout the presentation. What I see here thus far in the chat is someone having a difficulty with receiving CEUs. If you've had that thus far, my apologies. User error again on my part, but please email me at sbarnes, which is BARNES, at carepatrol.com. Now, I've heard from some of you that my email is bouncing back, and I think that may be because the email that you're receiving is either generated by Zoom, SurveyMonkey, or a email program that we use. And so when you reply to that email, it may go just out into the ether and not come to me. So please make sure if you're emailing me that you use sbarnes@carepatrol.com. As we've said before, and of course this won't apply to anyone listening unless you drop off, but we can't allow folks to participate and join after 12:20 because we have to prove to the boards of social work and nursing that we've received at least 40 minutes of the 55 allotted minutes of instruction. So at 12:20, we will not be letting anyone else in. While this may not affect you today, just be mindful in the future that after 12:20, we cannot let anyone in. Evaluations are due today by 5 p.m. They are done through SurveyMonkey. You will see, or you do see at the bottom of the screen, the address for today's survey. For those of you on the phone, I will read this for you if you have a pen handy. Those of you on the phone, the SurveyMonkey link for this evaluation due today at 5 is https://www.surveymonkey.com/R//V63Y82L. So that's today's SurveyMonkey link. I'll be giving it again at the close of today's presentation. And along with, in the midst of our presentation, we'll give to you the CEU code word, which must be included in your survey evaluation. So please be listening for that. We should then by tomorrow, Friday, have digital copies of paper certificates emailed to everyone who completes the survey today by 5. Those certificates should be mailed either later this evening or first thing in the morning. So I'm hoping we get a little bit more, that I get a little bit more efficient with the CEU certificate process. And as I've said to many of you who've emailed me, I appreciate your patience, and it is all, again, user error on my part. Lorraine asked if we could repeat the SurveyMonkey link, and I'm happy to do that. If you're ready. Oh, Melissa Mays has typed it, but Melissa, you've left out one important thing in the address, which is HTTPS. And that's important for this reason. If you see any website that has HTTPS, HTTPS in the beginning. The S stands for secure server. And what that means is you can share personal information like your license number and your names and your emails via that without fear of it being captured somehow and used to market you. So the address for SurveyMonkey is https://www.surveymonkey.com/lowercase r/uppercase V as in victory 63Y82L. So I hope that you've gotten that. Again, I'll repeat it, and if anyone needs it repeated, just get to me. When you're working with Care Patrol, our service area, though I'm located in Birmingham, I own the business. We have employees that work in Florence, Huntsville, Decatur. We're adding staff in Birmingham, Tuscaloosa, and Montgomery. Those are our service areas, primarily where there are, senior communities in abundance. We also try and serve the areas in between, points in between, but there aren't as many options there for folks, unfortunately. But you can see each of us here on the screen. S. Barnes at Care Patrol, D. Tyler, Dixie's in Decatur, Huntsville, T. Talley, Talley, Tracy Talley is in Huntsville and Russellville, Scottsboro, that area of the state, and Jennifer Redding's in Florence, the northwest corner of the state, stretching, east to Decatur, Huntsville, Athens. So we've got great coverage for you in North Alabama. We're working to get better here in the lower central part. And I believe everyone really is pretty much in now, so I'll get going. Our objectives today are threefold. One of them is to learn why seniors and individuals with dementia present in the emergency department. One is to learn the issues regarding dementia, reversible dementia, and delirium. And one is to understand the essentials of preparing for an ED visit with an individual who has dementia. So those are today's objectives. And here's the thing that I think we know, but let's state it again. Dementia is not a normal part of aging. While folks do develop dementia as they age, and most often as they age into their 80s and 90s, it's not a normal part of aging. It's a disease state. Normal, aging, age-appropriate forgetfulness would be forgetting where your keys are, or even maybe forgetting the name of a distant relative or friend from church from time to time. That's not dementia. Dementia is forgetting what the keys are for, which is different. Dementia is using nonsensical language, and that's not normal in aging. Depending on who you ask, there's somewhere between 80 and 200 diagnoses, different types of dementia. That's astonishing. And as you know, we really can't tell truly what type of dementia unless we do an autopsy. So of all of these various types of dementia, the two most common that make up 80% are Alzheimer's and vascular dementia. These sometimes present as mixed dementia. For example, you may have someone who has Alzheimer's, who also has high blood pressure, who has a stroke, and due to the stroke, they develop some sort of vascular dementia, as well as maybe debility in their motor skills. But then they had that's exacerbated by the fact that they already had Alzheimer's. So that's mixed dementia, and vascular and Alzheimer's can present very differently. Or differently enough that you have a cumulative effect that is really quite a lot to handle. There's the Lewy body disease, most often called PICS, and this is a motor skill, more affects motor skills. As many as 10% of people with dementia have Lewy body disease. And then there's the frontotemporal dementias, which again involves some motor skills, some bowel control, things of that nature. And they really are not understood, the frontotemporal dementias, as well as some of the others. So in the USA, 6.2 million people live right now with dementia, and the average age of diagnosis is 80.7 years of age. This increases by percentage dramatically as people enter the second half of their 80s and into their 90s. You see that the progression of folks developing dementia escalates by percentage greatly with age. The thing about any types of dementias that we may encounter is, for one thing, the dementia preceded, and usually by 5 to 7 years, precedes the diagnosis. And those of you that have been through this may look back and really think, yes, that makes sense, because about 5 to 7 years before mom started exhibiting, dementia, this incident happened. At the time, I didn't think anything of it, but now I realized that it was the beginning. And so mom, if she gets a diagnosis of Alzheimer's, life expectancy is 8 to 12 years. So we need to plan accordingly for how we're going to care for someone who diminishes gradually over that time span. If someone has been diagnosed with having vascular dementia, we're looking at a much lower lifespan of 5 years, and Lewy body can be as few as 2 years life expectancy after diagnosis. And then Huntington's is sort of an anomaly. It's part of what we discussed last week, the neurocognitive mental disorders, major neurocognitive mental disorders. And so Huntington's is within sort of the parlay of dementia, although Huntington's is usually diagnosed in the 40s and can be a lifelong disease for which there is no cure and little symptom management. So a much, I think, harder, different road for the younger person who's diagnosed with Huntington's versus the 85-year-old diagnosed with vascular dementia. But that's just maybe me being biased. So when we look at what happens and who goes to the ED by incident, we find that all ED visits in 2017, due to a study that I discovered, 32% of all emergency department visits were related to falls. Now, to give you a sense of how many that is, that's out of 144 million emergency department visits in 2017. 26 million of those were with cause. In other words, a cause was identified as the reason for being there. And of that 26 million with cause, falls were 8.6 million of those, 32%, 32.6% to be precise. Now, struck by and against, where you might think of someone struck by an automobile, for example, on a bike, because that age range 10 to 24, that's the most prevalent reason why someone in that age bracket would be in an ED, would be that they've been struck. And that is a much lower percentage than falls. It is down to only about 4 million versus the over 8 million falls that are identified. Of the Medicare incidents within the emergency department, 71% of these relate to a fall. 71%. And to give you some perspective, just to think about wherever you are, that rate per 100,000 is about 2,600 different incidents. Okay, 2,600 people. And in Birmingham, you're looking at 26,000 falls a year. If you multiply out, that's quite a lot. And so this is the reason that we're addressing today the ED, dementia in the ED, and falls in the ED. So let's look at dementia by service provider. So not presenting in the hospital in the ED, but nevertheless in other healthcare settings or dementia care settings. We found that in adult day care, 30.9% of the residents, or I guess attendees at adult daycare, are said to have dementia. And this is the source is listed here for you. But in 2016, 30% of those in adult day had dementia. In residential care, which would be independent living, assisted living, 41.9% of those folks who come to the ED have dementia. In home health, you're looking at 32% have dementia. And this is where I'd be interested to learn from any of you working in home health, if this number rings true for you. If you feel that of the folks that you visit, that about 32% of those people are living independently, perhaps unsafely, nonetheless alone with dementia. In hospice, we see 44% of those folks have dementia. And in the nursing home, 47% of folks in the nursing home have dementia. And you may be tempted to say, well, clearly folks in the nursing home are older. That makes sense because people develop dementia as they age. It's not really true. The nursing home median age is far below that of assisted living, for example, which is 82. So, you know, it makes sense to me that you would see 41%, and I would think really higher in community living that would have dementia. And I really would think, from my experience in adult day care, that those, the majority, in my experience in visiting adult days, and we have 5 or 6 in Birmingham, you may have them in your area, you may not, that not every area does, but in visiting them as I've done, I would just about believe that most everyone there out of 6, 8, 10, 12 people had dementia. And so I think that might be something that's underreported or, you know, misreported, would be my feeling about adult day. And the thing is really, truly, most adult day programs are geared for people with dementia. I love referring folks to adult day, particularly say the adult child, mom or dad who has dementia is living with them. The dementia has progressed. They're starting to worry about mom getting out of the house and getting lost. So adult day is a terrific solution and a cost-effective solution for folks in that arena, because you're looking at $40 to $65 per day versus $130 to $160 per day in assisted living to $315 a day in nursing home. So it's a great economical way to make sure that someone is safe and fed. And I'll tell you, the people that run adult day, these are not people that are doing it because they expect to make a lot of money. In fact, I would think they expect not to make a lot of money, because generally people that run adult daycares don't. It's almost always a mission of a faith or a church, or it is the mission of an individual who simply wants to see that the elderly folks in our community, particularly those with dementia, are cared for. So that's my soapbox on adult day. I apologize. What we see with dementia in the ED is that elderly adults with dementia are more likely to visit the ED than other elderly adults. They're more likely to be admitted to the hospital, and they're more likely to die following a visit. And this can be statistically within a week. So there are folks presenting with dementia in the ED, they're discharged for whatever reason, and then they go on to either be readmitted a week later or even die. This is a study that is in part done with Indiana University and the Reagan Streif Institute. I think I pronounced that right. I went to Google and said, how do you pronounce this? And so I believe I've done that correctly. But I mean, this is sobering to me to see that we have this population of people, coming into the ED with dementia who are not being cared for. And this study really sort of gets to the heart of that in some ways. There's a belief in the study that between 1/3 and 1/2 of all people with dementia visit an emergency department annually. So we're talking about folks who might be, we have 6.2 million people in the US, so somewhere between 2 and 3 million annually visit the emergency department who have dementia. This was a study of 33,000 people, and it occurred over 11 years. So I trust the data here. And their treatment, not surprisingly, cost more than those without dementia. So this is the summary by the author of the study. It's a Dr. Dementia, who is a professor of medicine. And he says, we know now that survival rates after an ED visit differ significantly by cognitive status, which is what we've just discussed. And what he suggests is that emergency departments aren't necessarily the right setting for the person with dementia, because the evaluations and treatments involved are more of a primary care nature, not an emergent nature. And it takes more time and more resources than are available typically in the ED. And so what we're really sort of getting at here is that EDs are ill prepared to serve someone who has dementia, for all of those reasons, or all of which are credible and believable and absolutely, forgivable. The study from the Reagan Streif Institute found that 53% of the dementia patients who presented in the ED were discharged home. And so the researchers were asking, well, were these ED visits medically necessary? And this is where you might say, given dementia, perhaps not. Perhaps it was just one of those things that folks who have dementia do unexplainably, such as call the 911 and go to the emergency room. But it could be that there were things missed, that physicians weren't equipped, as was just said, with the tools and the training to catch the dementia person presenting and understand that they needed to be admitted, in other words. So Jay found this statistic. I have not been able to reproduce it, unlike everything else. He left a roadmap for me in terms of these. So I haven't found the Fierce Healthcare report that states this, and it is a little bit an aside, but I think it's worth pointing out or being aware of, is that, of these folks who 1/2 to 1/3 of folks with dementia present in the ED. Among all the elderly folks, that's about 53%. So of those, 1 in 10 are victims of abuse, sexual, emotional, financial, physical. And I would think that dementia would be I don't want to say cause, but certainly a combined to all of these types of abuse, particularly if you have a caregiver who's stressed and overwhelmed and overworked, or other things. Again, returning to the home, if you are a victim of this type of abuse with dementia, again, almost assuredly says you'll be back in the ED sooner than later. So we've already touched on the fact that these adults who have dementia are more expensive to treat, and you can see the numbers here. And interestingly, in the last 5 years of life, the most expensive condition to treat is dementia. And I would think this would be both ancillary things like medical equipment and depends, as well as the cost of care in places like nursing homes and assisted livings, as well as the frequent visits to the ER due to falls primarily or other reasons. And what are the reasons? Well, the reasons that seniors present to the ED are, again, number one, and far outpacing all others, falls. Then there's the pneumonia UTI. So again, these conditions you would think, not necessarily would someone have dementia who had a UTI, but you would expect someone who has dementia to have UTIs because of the lack of things like remembering to hydrate or other things. What's interesting to me, and we'll see a little bit later in the slides, a study was done at UAB here in Birmingham, and it's that people who have dementia, who go to the ED and then are discharged home, are less likely to move about as freely in their environment as they once did. And so what would you think this would lead to? Well, I would think that it would lead to pneumonia. So if you have someone that's seated in their chair, not standing and sitting and standing and sitting and walking and being active, but rather sitting or laying on a couch or laying back in a recliner, these are the people I would expect to develop a pneumonia. Polypharmacy events are high on the list of reasons for seniors being in the ED. And again, I would say a culprit to this would be dementia, folks that either do not take their medications or folks that are taking medications that they don't have their physicians clued in, that the one has them on this and one has them on that. Or it could be that they're taking more medication than is necessary because they either forget or because they're abusing medication. Chest pain is number 2 for reasons that people present, seniors present in the ED. And of course, this is self-explanatory. What we are going to look at here in a moment are those that present with delirium as opposed to those that present with increased confusion or other behavioral issues. So those are the reasons that we find seniors in the ED. And again, I would say that many of these probably are related in some fashion to the person having, some stage of dementia. So we have to ask ourselves a couple of things. One, what is today's CEU word? It is delirium. For those of you by phone who may be spelling challenged, that's DELIRIUM, delirium. The CEU word for today, you'll need that when you go to SurveyMonkey following the presentation to do your evaluation by 5 today. So remember, the CEU word for the day is delirium. And we know it's an acute brain failure. It occurs in about 10% of older emergency department visits, and it's associated with higher mortality rates, and it can be quite frightening to see. And anyone who's had an elderly family member, loved one, client in a hospital setting, in the emergency room, you do not need to put all caps on the survey, Charity. I don't believe, just delirium. I lost my place, but we see that delirium with demented patients leads to an acute decline, a fast and rapid decline in performance and mental status. It's so rapid that it spins your head. And while it may be mistaken as rapidly progressing dementia, delirium is reversible. The way that we suggest that clinicians in the ED screen someone for delirium or dementia is to use the EDDTS, the ED delirium triage screen. And it takes about 20 seconds, and it involves what is called the Richmond Agitation Sedation Scale, or the RASS. And that is whomever is, admitting the patient, the nurse would look at the patient and try and determine, where are they on this Richmond scale? And that the Richmond scale is used primarily for anesthesia of ventricle, trach type folk patients, but it can be used in any setting. And in this setting, in the ED, it's used to determine what state is someone in, sort of emotionally, mentally, physically. So that it starts with combative and moves to very agitated, and then agitated, and then restless, and then alert. And alert's sort of the middle. And then it would go all the way on the other scale to unarousable sedation. So we would use that, and this is quick, right? It's 20 seconds. What do they look like? Are they inattentive? Are they sedated? Are they agitated? Are they calm? And then the second question that the nurse would give would be under the delirium triage screen would be spell lunch backwards. And this is a way for the nurse to tell if there's any cognitive issue with the person, any inability to think or reason or remember something that should be fairly easy to recall. And so the other thing, so if we do the triage screen and we find that there is no evidence of delirium, then we do nothing. If we think that it's a positive, that there may be something, then we do use the confusion assessment method, or CAM. Now, if you Google CAM, you'll get something related to automobiles. But if you Google confusion assessment methodology, you can find out more about that. But basically, it has 4 questions, 4 methodologies. And what they want to see is, and these are all done by interview. So the nurse who's still doing the assessment would simply interview the family member or the person who brought them in and ask them, hey, was there an acute onset of this behavior? Has it fluctuated? Was it stronger in the morning or in the afternoon? They would ask, were there periods today when you tried to interact with the person and they seemed inattentive or not following what you were saying? And then the third question they would ask, and this is again from assessment by the person who brought them in, is do they appear to have disorganized thinking? So are they, again, trying to do things out of order, or using something in the wrong way, or using language in the wrong way, or having, making statements that are preposterous? So we would use the EDDTS, the delirium triage screen, and if it was positive, we would then go to the confusion assessment methodology. And if at that point we realize that we have the presence of delirium, then we can act more appropriately. And as we are proposing today, we would admit those patients. So in the difference in the two of dementia and delirium is sort of summed up in that dementia develops over time. It's an impairment in short-term memory and cognition, and it can have speech or language effects or issues. Delirium, on the other hand, is acute and it's a fast onset. It involves an alteration in consciousness. So again, we're using the Richmond agitation scale to see what does that alteration in consciousness look like. Their cognition, we're spelling lunch backwards, perception. If they have disturbed memories, if they have a fever, certainly we know there's delirium or something present, an infection. They might be agitated. We would know this upon our first assessment, and we would determine if they were aggressive, again, by the Richmond agitation scale. So all of these things would prove positive for the patient with that use of tools. Whereas with dementia, we would be negative, right? Because this is a long-standing issue and problem. lost my mouse. I guess the easiest way to determine delirium versus dementia, or reversible dementia for that matter, would be through lab work. And so we know that if there's an infection present, that there's likely, that this is likely related to a delirium, like a UTI delirium. It may be an electrolyte imbalance. Again, we may find that someone is dehydrated or has not been eating properly. It could be a UTI. It could be some other type of infection. It could be a wound that's gone unchecked. It could be an intoxicant, something that someone, took either on purpose or by mistake in terms of medication. It could be low blood sugar. Many of us have friends who are diabetic, and we've seen the changes that can be wrought when someone is having a crisis with their diabetes. You might see low oxygen bring someone with delirium to the ED, thyroid abnormalities, or polypharmacy. And this polypharmacy is a culprit in reversible dementia and delirium. And this would be, again, I think the purveyance of someone with dementia might apply here, because you have folks that maybe aren't cross-checking with their physicians. They don't know to, or don't remember to, the medications they take. Reversible dementia are things like, you see this sometimes with alcoholics. I've admitted alcoholics into memory care from behavioral health in a hospital who were able to, upon quitting drinking, graduate, so to speak, first to assisted living and later to independent living. So the dementia associated with alcoholism can be reversed to some extent, although the damage can be done in some cases. And certainly if there's a cirrhosis of the liver present, as we discussed on Tuesday, then you would find that this would not necessarily be reversible. Now, depression and dementia are so closely linked. You find that folks who have depression are more likely, for example, to develop dementia, and many of the same things present: a flat affect, a lack of interest in activities. But if we can solve or treat that depression, we can, in that case, certainly with that older type person, reverse what we thought was dementia. Of course, brain lesions, if they heal appropriately, can have someone have the reversed in dementia. If we, for example, cure a B12 problem, then we can reverse what appears to be dementia. Central nervous system infections. So if you had meningitis, for example, this, as the infection cured with antibiotics, you might see that reverse. And then there are hearing issues. And I've located someone to do a hearing CEU for us. So I look forward to that down the road. Now, polypharmacy, this is the culprit in both. So we want to take a minute with it because it affects all of us, certainly affects seniors, and most definitely adversely affects seniors with dementia. So there are 3,500 people aged 65 over that were studied over a 7-year period. And they were taking over-the-counter prescription anticholinergics. And I hope I've said that properly. It's really hard for me. Anticholinergics over a 7-year base. 23% of those folks developed dementia. And 54% of those developed an increased risk 3 years later. So what we see is there's very definitely a relationship between these medications, which are prescribed many times for the elderly, like anti-Parkinson drugs or antispasmodics for someone that maybe has IBS, or anti-migraine bronchodilators, someone with COPD. So you have pre-anesthetics. Anyone going into surgery would be treated with these drugs. And again, we see that they affect adversely and directly and relatably with data. They affect and even cause, in some cases, dementia. And then there are those drugs that have side effects like the anticholinergics, and these would be the most often of use would be antihistamines. And so we all sort of know that antihistamines and NSAIDs are not recommended for those who are older. And then you see all these anti-ulcer drugs. How many people are on Pepcid or something like that we see in clinics every day? So these drugs are perhaps leading or certainly contributing to the increase in dementias in the United States, in the developed world, where we're increasing rapidly. So now we want to get to, what do we do if we are a caregiver, loved one, sponsor, clinician who is accompanying someone with dementia, or truly really any elderly person, but certainly someone with dementia, to the emergency department? The number one thing is, I just say that I'll go off track here. The number one thing is stay by their side. Stay by their side and make sure that you're an advocate, that you're asking questions, writing things down. This is your most important job. But when you're there and in preparation to go to the ED, you want to have just packed in your car, your glove box, your trunk, somewhere that's always with you, their advance directive, their medical power of attorney, or any other powers of attorney that you have, any emergency contacts. You want to make sure that you're contacting folk along the way. We suggest a memory book. You can Google these. There's a whole cottage industry out there of memory books, but it is what you think it is. It's just a series of pages in which you post photographs or awards or flower pressings or whatever, and with a little bit of information about it. And what you do, particularly with the dementia patient in the ED, is a calming mechanism and a redirect, is you go through that book and you just go through and you say, well, look at this. Do you remember when we did this with your sister and your cousins, whatever it might be? You go through that. And that's a way that you can keep the situation calm, which is otherwise, as you know, in an ED, very chaotic. And then you want to go already having investigated, and this is where someone like Care Patrol can help. You want to go having already investigated, what are your proposed plans for discharge, A, B, and C. And I would suggest that A, if it can be, if they're medically qualified for a rehab stint, that be A. If not, I think that A would probably be, if they're returning home, to engage sitters, at least for the first few days, the first week. Okay. You would want to engage them as part of your discharge plan. And this is one of the things that Care Patrol helps clients do, is understand, what do I need to do now and in the future? So this is sort of part of what we do. We get to show you today. You also want to have, and my mother, who was formerly a secretary and later taught business classes at the University of North Alabama in Florence, she carries a binder, 3-ring binder of her medical history every time we go to the doctor. And while she can't quite understand what it says anymore, I have it. And I can say, well, no, the last time she was here, this is what you said, and we tried this, and whatever. You also want to have the ability to restate, to list the family medical history. So if mom, sister, and great aunt had the same condition, then that's something that's going to be important to know. You also want to know, and this would apply to, for example, determining whether we have a delirium, a dementia, or a reversible dementia. You'd want to know their historical use of alcohol and drugs, including not only illicit, illegal drugs, but their prescription and over-the-counter drugs. And you'd want a complete list of those medications that were prescribed or were being taken on a daily basis. And this can all, again, be put in a quick 3-ring binder, but it's something you want to have at your disposal every time you are in the ED or even at any doctor's appointment for that matter, with an elderly person. Now back to the power of attorney. If you are living, working, caring for, caring about, taking care of someone with dementia, and you don't yet have power of attorney established, the problem is that it's too late, because the court would say, or anyone that might protest the power could say, that this person was not in their right mind. They weren't capable of assigning this duty because they're not capable of making those types of decisions anymore. And if that's the case, then you will not be able to get a medical power of attorney. What you'll have to do instead is appeal to the court for guardianship. This can be done using any number of lawyers. I would suggest, if you're in that situation, find the county conservator where you are and try and employ them as your attorney. That's what I did with my own mother. And so, use that resource, but you're going to need to petition the court for emergency powers. Certainly if someone is in or on the way to the hospital, on the way, probably too late. But, if they're in, you can make a quick call and say, hey, how quick can we get this started? I've got to make some decisions about mom's care. And that can be done fairly quickly. So the power will be granted fairly quickly. And then it's renewable every 15 days until such date as an actual court date, which given COVID could be, anytime, who knows? So as I said earlier, the most important thing you want to take to an appointment to the ED with an elderly person, and in particular, an elderly person with dementia, the most important thing you want to take is yourself and your full attention and your advocacy for that person. So if you are in that role and the doctor or the nurse turns to you and says, ABCDF, then you need to use that sort of communication skill and say, what I'm hearing you say to me is ABCDF, and clarify so that you know what's being said. You're fully conscious and cognitive of what is needed next, and then writing down information as it's given to you by the clinician, carrying out the patient's request, keeping track of all medications, but most of all, making sure the patient's rights are met. That is your role. And again, if you're caring for someone with dementia, they no longer can perform that role for themselves. They need you. And our health system needs folks like you, because again, we make some issues, we make some mistakes due to lack of time or tools or training in the ED, where maybe we should be admitting some folks who aren't admitted. And this is where you as a patient advocate can share more of the story to the clinician, who can then make a better decision because they have more information. So that was today's CE for y'all. If anyone has any questions, I hope you'll post them in the chat. I didn't see any comments today, which makes me think we didn't hold your attention. I hope we did. The CEU code word is delirium. It's not all caps or even cap at all. And the survey address for SurveyMonkey, one more time, is https://www.surveymonkey.com/r/V as in Victory 63Y82L. So please go to SurveyMonkey to that address today before 5. Use the code word delirium. Be sure to leave your email and your ABN or social work number with me. Or if you are a different, if you're a PT or OT or some other discipline, leave that number with me, please. If you, dialed in by phone, I'll need your email address. So please do make sure you put that in there. And as always, we appreciate you listening in. We appreciate you staying with Care Patrol Education now that It's in my hands and no longer in the capable hands of Jay Jones. We appreciate what you do for your families, your neighborhoods, your communities, and most especially your clients and patients. And we very much appreciate when you think of us and refer us to folks who present with a need for more information and guidance around what to do with senior care issues. So thank you, everyone. I see, again, there's not much activity in the chat room. We're a little early today, but I guess you can take the next 5 minutes, and if it's pretty where you are, go out and sit in the sun and enjoy it and take some deep breaths and have a great rest of the day. Thanks, y'all.